Welcome back to the deep dive. You know, in the emergency department, there are a few things that get your attention quite like acute chest pain.
Hmm.
We're constantly walking this tightrope, aren't we? Between, trying to safely discharge someone and the fear of missing a life-threatening MI.
Absolutely.
So today we're getting into a really critical document, a systematic, evidence-based framework for managing suspected ACS, acute coronary syndrome, tailored specifically for, well, for our world, the ED.
And that's the mission, isn't it? This isn't just another guideline. It's a real attempt to standardize a very high-risk workflow.
Right.
We're essentially synthesizing a protocol that's all about bringing precision to that need for speed. It guides everything from the initial assessment to diagnosis, and crucially, the rapid rule-out or rule-in of myocardial injury.
A roadmap, basically, for a diagnosis where every single minute counts.
Exactly.
Okay, so let's unpack this, because the protocol starts, interestingly, not with the heart, but with a sort of mandatory step back. It forces you to look at the bigger picture first.
It does. It puts the burden of differential diagnosis right at the top, the foundational prerequisite.
So you can't get tunnel vision on ACS.
Precisely. The protocol is crystal clear. The ACS pathway only begins once you have actively considered and, addressed the other immediate life-threatening causes of chest pain.
That's non-negotiable patient safety, right?
That has to be. If you skip that step and you've missed a dissection, the rest of the algorithm is, well, it's irrelevant.
So for everyone listening, let's just quickly run through that mandatory list. What are the specific killers we have to actively exclude before we even think about committing to the ACS pathway?
Okay, so it's the classic don't miss diagnoses. You've got your big vascular and pulmonary catastrophes. So aortic dissection, a big pulmonary embolus, and a tension or large pneumothorax.
The big three.
Then you have to think about the gut. So an esophageal rupture, a Borhaves type picture, and then the slightly less dramatic but still serious things like a significant pneumonia or referred pain from something nasty in the abdomen.
Ah, the great masquerader. That intra-abdominal pain.
Pancreatitis, cholecystitis, yeah, it can absolutely catch you out.
That focus right at the start is so vital. We can get so fixated on the troponin that we forget to even think about, say, a D-dimer in the right context.
Well, this protocol tries to prevent that. It grounds the whole process in good clinical practice. We only move on once ACS is the most probable diagnosis, after those other things have been properly considered.
Right, so clinical permission granted. We move to step one, the initial clinical assessment. The protocol points to the nice guidance here for the key triggers. What features should really raise our suspicion?
So we're looking for the classic risk amplifiers. First is the pain itself, chest pain, or that typical referred pain to the arms, back, or jaw that lasts longer than 15 minutes. Duration is a really key factor.
And the associated features.
Yes, that's the second bit, the autonomic activation. So pain that comes with marked sweating, nausea and vomiting, or significant breathlessness. If you get a combination of those, your suspicion index just skyrockets.
And what about hemodynamic instability?
An absolute escalation trigger. Any of this pain in the context of hypotension or a new arrhythmia, you have to act immediately.
Okay. And the last one is about angina, right? A change in the pattern.
Yes. New onset pain or a really abrupt deterioration of what was stable angina. So the episodes are happening more often with less effort, and they're lasting longer than 15 minutes. That's a huge red flag for unstable disease.
So if you've got those features, you can't wait. And that brings us to step two, which is immediate and mandatory.
The 12-lead ECG.
This is probably the most time-critical part of the whole thing, because a clear result here can bypass the whole troponin pathway.
It's the primary tool for spotting an acute occlusion. It's binary, really. You see the occlusion, you activate the cath lab.
And the protocol is clear. If the ECG shows a classic STEMI or a STEMI equivalent.
Immediate activation. Primary PCI. Time is myocardium. There can be zero delay at that point.
I'm glad you mentioned STEMI equivalent. That's so crucial, isn't it? It's not just about classic ST elevation anymore. We're talking about occlusion MI patterns.
Yes. Exactly. We have to train our eyes to see beyond the textbook stuff. The work by people like Ricci reinforces recognizing these subtle OMI patterns.
Things like an isolated posterior STEMI.
Yeah, which just looks like ST depression in V1 to V3. Or De Winter T waves. Or that pattern of widespread ST depression with reciprocal elevation in AVR.
All of which signify massive disease.
And they warrant the same immediate cath lab activation. We're treating the physiology of acute occlusion, not just, a line on a chart.
That is such a key point. It forces us to use our ECG interpretation skills right at the front door.
Oh.
Okay, so let's say we've cleared the immediate occlusion risks. No STEMI, no OMI, but we're still worried. That's when we get to the blood tests.
Correct. Step 3, the high sensitivity troponin. This has revolutionized things, but you have to stick to the thresholds.
And for this protocol, a positive test of significant injury is defined as what?
It's a second troponin level that's more than 120% of the initial value. From there, we stratify the patient into green, amber, or red pathways based on that first result.
Okay, let's start with green, the low-risk group. What's the criteria and what's the all-important safety net?
The green pathway is for an initial troponin of less than 5 nanograms per liter. The data on this is really robust. It shows an extremely low risk of major adverse cardiac events at 30 days.
There's a big but.
A massive one. This is the cornerstone of safety. If that low result was taken when the patient's pain started less than 3 hours before the blood test.
The troponin might not have had time to rise yet.
Exactly. So that patient must be managed via the amber pathway instead. We absolutely have to protect that very early window.
That 3-hour time point is the key. So moving up to amber, this is where the pressure is on for a quick decision. This is for initial troponins between 5 and 11 or those early green presenters.
This is your definitive 1-hour rule group. The mandatory next step is a repeat troponin at exactly 1 hour.
And it's the change, the delta, that gives you the answer. Why is the threshold a change of 3 nanograms per liter? What's the significance of that number?
It's all based on validation studies. It's the point where a dynamic change is highly predictive of a genuine acute injury, rather than just, chronic leakage from renal failure or something else.
So if that change at 1 hour is more than 3,
they're ruled in for ACS. That tiny dynamic rise confirms acute injury. They need to be referred to acute medicine and get full ACS treatment started.
and if the delta is less than 3, we can start thinking about discharge, as long as they meet all the other safety criteria. That rapid rule-out is a game changer for ED flow.
It completely transforms it, but only if you stick to the rules.
Okay, finally, the high-risk red pathway. What's the initial troponin that puts a patient here, and how does our timing change?
Any initial troponin over 11 nanograms per liter is the red trigger. This group has a high pretest probability, so we switch from a 1-hour rule-out to a longer observation. The repeat test is at 3 hours.
The disposition for these red patients can be a bit more nuanced, especially around SDEC, same-day emergency care. When can a red patient, despite the high number, potentially be suitable for SDEC?
Right, so SDC is for when we found an injury, but it looks small and stable. 3 criteria have to be met. 1, the ECG is normal or nonspecific with no dynamic changes. 2, the patient's pain is completely gone.
Okay.
And 3, the initial troponin is in a specific range between 12 and 42 nanograms per liter. If they're stable and in that zone, a rapid workup via SDEC can be appropriate.
So that 42 nanogram per liter cutoff is a major line in the sand. If they're above that or still have pain, SDEC is off the table.
Completely. Urgent inpatient referral and full ACS treatment are mandated. Any ECG changes, a critically high troponin over 42 or more than 3 times the upper limit of normal or ongoing pain, any of those, and they need a bed immediately.
It's a clear marker for when to ramp everything up. Okay, let's bring it back to the exit door. For our green or amber rule-out patients, the ones who are biochemically clear, safe discharge isn't automatic. They have to meet all 3 mandatory conditions.
Yes, all 3. First, no other reason for admission. Simple enough. Second, the ECG must be pristine. No concerning features, no dynamic changes.
And the third?
We have to have proactively considered and appropriately investigated an alternative non-cardiac cause for their pain.
Which brings us full circle, right back to where we started, the differential. The troponin might be negative, but if you still have a potentially high-risk alternative diagnosis that's uninvestigated, you haven't finished the job.
Absolutely. The rule-out has to be clinical, not just biochemical.
And this leads perfectly to the idea of the clinical override. The protocol reserves this for the senior clinician, the RA doctor or above. When do we overrule the algorithm, even if the numbers look good?
This is where we have to trust our clinical gestalt. The protocol highlights 2 scenarios. First is just persistent clinical concern. If a senior clinician is still worried, despite negative troponins, that concern wins.
You treat the patient, not the test.
Always. And the second, which is so often missed, is a presentation concerning for crescendo angina.
Can you just quickly define what we mean by crescendo angina in this context? How does it differ from stable?
Crescendo angina is a rapidly escalating pattern. The pain is coming on more frequently with much less exertion, and it's lasting longer than their usual pattern. It suggests a coronary lesion is becoming critically unstable.
So even if the troponins are negative at that exact moment,
That patient is unstable. They have to be admitted for urgent cardiology input. Full stop.
it's such a powerful reminder that this is a guideline to standardized care, but it absolutely does not replace sound clinical judgment.
That's the ultimate synthesis. The system gives us clear time points and thresholds, the 1-hour rule, the 3 nanogram delta, the 5 and 11 cutoffs, but it starts and ends with clinical thought.
So the key takeaway is that balance. The high-sensitivity troponin pathway is incredibly efficient, but its safety net is built on our clinical diligence.
100%. The initial exclusion of the killers, the vigilance for STEMI equivalence on the ECG, and that final override for unstable pictures like crescendo angina.
That's the art of emergency medicine right there.
It is. And just to build on that vigilance for STEMI equivalence, that Ricci review doesn't just reinforce acting on them, it really challenges us to see the ECG as the definitive tool, even before the troponin has a chance to rise.
Which leads us with a question to take away, really. How well are we as a community training ourselves and our teams to recognize the subtlety of those oh my patterns that fall outside the traditional STEMI box? Because mastering that skill is what defines whether we activate the cath lab in time, regardless of what that first troponin number says. A truly fascinating and essential deep dive.